Hello, anesthesiologists. Thank you for your hard work administering regional blocks today. Starting today, I would like to review the confusing and difficult ESP blocks and QL blocks in detail over 2 installments. Bonjour, chers anesthésistes. Merci pour votre excellent travail lors de la réalisation des blocs régionaux aujourd'hui. À partir d'aujourd'hui, je souhaite passer en revue en détail en 2 parties les blocs ESP et QL qui peuvent s'avérer complexes et difficiles à maîtriser. Welcome to this explainer. You know, since Mauricio Forero first described the Erector Spinae Plane Block back in 2016, we have witnessed an absolute explosion in the literature. It genuinely represents a new paradigm in ultrasound-guided regional anesthesia. Today we are going to unpack exactly how this fascial plane block has completely revolutionized post-operative pain management, and we'll dig deep into the nuances that elevate a good block to an exceptional one.
Our agenda for today is split into 6 main parts. We'll start with anatomy and fascial barriers, move into the complex mechanisms of action, then cover ultrasound guidance and technique. After that, we'll look at clinical evidence and indications, followed by the safety and complication profile, and finally, wrap up with a pediatric focus and future directions.
Section 1. Anatomy and fascial barriers, where we'll be deconstructing the erector spinae muscle and the thoracolumbar fascia.
Now, to truly master this block, we absolutely must establish the foundational anatomy. What's brilliantly illustrated here is the erector spinae muscle complex itself. It's not just one mass, it forms the intermediate layer of the intrinsic back muscles, arising caudally from this broad, thick tendon attached to the iliac crest and the sacrum. Moving cranially, it splits into 3 distinct columns. Moving from medial to lateral, you have the spinalis, the longissimus, and the iliocostalis. These columns are tucked beautifully between the spinous processes medially and the angles of the ribs laterally. But here is the critical clinical pearl for your ultrasound practice. Layered superficially over the erector spinae in the upper back are the trapezius and the rhomboid major. However, the rhomboid major notably vanishes as you scan inferiorly past the T6 or T7 level. So if you're performing a low thoracic ESP block, say a T8, and you're hunting for that rhomboid layer on your screen, you simply won't find it. Recognizing this muscular topography is absolutely vital for correct transducer placement and ultimately accurate fascial plane identification.
Moving a layer deeper, we encounter the thoracolumbar fascia, which is anything but a simple sheet of tissue. It is a highly complex, dynamic barrier divided into 3 distinct layers. The posterior layer envelops the erector spinae and latissimus dorsi. The middle layer sits snugly between the quadratus lumborum and the anterior aspect of the erector spinae, and the anterior layer runs anterior to the quadratus lumborum and psoas major. But where it gets incredibly fascinating for us as anesthesiologists is when we examine the ligamentous barriers detailed in this table. We have the intertransverse ligaments forming distinct bands, and just beneath them, the superior costotransverse ligament. For decades, traditional anatomy taught us that this costotransverse ligament was an impenetrable, thick, fibrous band. But recent, cutting-edge anatomical literature suggests it may actually be fenestrated. It has tiny openings. Why does this matter? Well, this fenestration theoretically permits your local anesthetic molecules to diffuse anteriorly, sneaking right through the ligament into the paravertebral space. This single anatomical quirk is at the very center of an intense, ongoing debate regarding how this block actually achieves such profound visceral coverage.
Section 2. Complex mechanisms of action, covering the controversies and contrasts spread.
So let's dive straight into that debate. The crucial point of contention in our field right now is distinguishing between localized dorsal ramus spread versus true ventral ramus spread. If your injectate only coats the dorsal rami, you are essentially only providing a sensory block to the posterior back. That's fantastic for spine surgery, but it's not going to help your patient undergoing a laparotomy. To achieve true anterior hemithorax analgesia, you need ventral ramus spread, and that requires the local anesthetic to penetrate deep into the paravertebral space. When we inject properly, deep to the erector spinae muscle right at the tip of the transverse process, the anesthetic reliably distributes in a craniocaudal fascial plane. A good rule of thumb is that you cover roughly 1 dermatome for every 3.4 milliliters of injected volume. But for major thoracic or abdominal surgeries, that sheer craniocaudal volume isn't enough. The local anesthetic must be driven anteriorly through the costotransverse foramina and the intertransverse complex to catch the ventral branches and the sympathetic chain.
And this is where the data becomes a bit of a puzzle. As you can see in this summary table, the consensus on this anterior diffusion remains incredibly elusive. When we look at cadaveric dye studies, they show highly variable and, quite frankly, unreliable paravertebral penetration. Sometimes it gets there, often it doesn't. Conversely, when we look at live patient imaging, the data seems much more robust, frequently demonstrating excellent craniocaudal and beautiful anterior paravertebral spread. So what's going on? Well, we have to consider tissue dynamics. Cadavers like the rhythmic breathing, the muscle tone, and the intrathoracic pressure changes that might help pull that anesthetic anteriorly in a living, breathing patient. However, we also must be highly analytical and account for responder selection bias in the live patient literature. In many reports, researchers pre-selected responders, patients who had a successful sensory block, before conducting the MRI contrast study, naturally skewing the results towards showing successful paravertebral spread. It's a bit of a catch-22, but here is the silver lining. Even when anterior spread is slightly limited, the extensive craniocaudal dorsal ramus blockade provides profound clinical benefits, making it an incredibly forgiving block.
Section 3. Ultrasound Guidance and Technique. Practical Approaches to the ESPB.
Let's translate all these complex anatomical mechanisms into practical, ultrasound-guided technical execution. What you're looking at here is the classic parasagittal view. To get this, you orient your linear transducer parallel to the vertebral column, usually about 2 to 3 centimeters lateral to the spinous processes. Your first step to success is identifying the key bony landmarks, the transverse processes. Notice how they appear as these distinctively hyperechoic, rhomboid-shaped structures dropping off into acoustic shadowing. If you see a rounded, oval structure with pleura underneath, you're too lateral, you're on the ribs. Stay medial on those squarish rhomboids. Between them, you will spot the intertransverse ligament as a faint hyperechoic line. Just superior to this bony and ligamentous baseline lies the thick hypoechoic band of the erector spinae muscle. Your target is the fascial plane exactly between the deep surface of the erector spinae muscle and the tip of that rhomboid-shaped transverse process. It provides an incredibly intuitive and remarkably safe sonographic window for precise needle placement, keeping you well away from the pleura. Conversely, while the parasagittal view is arguably the most popular, some advanced practitioners highly advocate for this short-axis transverse view. In this orientation, you place the probe perpendicular to the spine. You identify the spinous process medially as a superficial peak, and then sweep laterally down over the lamina up to the transverse process, and then dropping off further laterally. The erector spinae muscle sits right over this bony contour. While both the parasagittal and transverse camps claim superiority, the truth is, the optimal sonographic window remains a matter of technical preference, patient habitus, and your own operator experience. In fact, if you are performing a lumbar ESP block, some experts prefer the shamrock view. By positioning the transducer in the flank between the iliac crest and the costal margin, you get a beautifully cross-sectional look at the erector spinae interacting with the transverse process, the psoas, and the quadratus lumborum. It's all about choosing the view that gives you the clearest trajectory.
So, let's walk through the actual procedural workflow. First, patient positioning. You can execute this beautifully with the patient in the lateral decubitus position or prone. Prone is especially brilliant if you are performing bilateral blocks or putting in bilateral catheters. Once prepped, insert your needle using an in-plane approach. Depending on your ergonomics and the ultrasound machine position, you can safely approach craniocaudal or caudocranial. Both are perfectly acceptable. Now, step 3 is absolutely paramount. Always confirm your fascial plane via hydrodissection with a small amount of saline or your local anesthetic before committing to your full dose. You want to see the injectate effortlessly unzipping the plane, physically lifting the erector spinae muscle straight off the transverse process. If the muscle itself bulges, you're intramuscular. Pull back slightly. Once you confirm that beautiful linear spread, you administer a standard adult weight-based dose. Because this is a high-volume block relying on spread, we typically use 0.3 to 0.5 milliliters per kilogram of a long-acting anesthetic, such as 0.25% bupivacaine or 0.2% ropivacaine, keeping a strict eye on maximum toxic doses.
Section 4. Clinical Evidence and Indications. Validating efficacy in the perioperative setting.
As anesthesiologists, we're always looking for clinical utility, and the versatility of the ESP block is genuinely staggering. Looking at the indications, we see it covering massive territory. In thoracic surgery, it is a game changer for video-assisted thoracoscopic surgery, painful open thoracotomies,
the Nuss procedure, and stabilizing patients with multiple rib fractures. Moving down, it provides excellent coverage for abdominal surgeries, from laparotomies and laparoscopic cholecystectomies down to complex renal procedures. We're even seeing it widely utilized in cardiac surgery, where bilateral ESP blocks are revolutionizing analgesia for median sternotomies, facilitating ultra-fast-track extubations. Orthopedically, it's brilliant for complex scoliosis spine surgeries, where the posterior elements are exposed, and even for hip procedures when done at the lower lumbar levels. Furthermore, in the chronic pain sphere, it's bringing relief to patients with thoracic neuropathies, CRPS, and acute herpes zoster. But perhaps its most significant role is acting as a highly reliable rescue block or primary alternative when epidurals are strictly contraindicated, such as in patients with severe coagulopathy, significant thrombocytopenia, or complex spinal anomalies.
We don't just rely on anecdotes, we have a robust comparative data matrix. When tested against non-blocked controls, the ESP block consistently and significantly reduces both postoperative pain scores and systemic opioid requirements. But how does it stack up against our other heavy hitters? Against the gold standard thoracic paravertebral block, ESP largely matches the clinical efficacy, providing similar opioid-sparing effects but arguably with a simpler and safer ultrasound window. It demonstrates clear superiority over standard intercostal nerve blocks, particularly for open thoracotomies, because one ESP injection spreads across multiple dermatomes, whereas intercostal blocks require multiple tedious and potentially risky needle sticks. For abdominal procedures like laparoscopic cholecystectomies, it stands toe-to-toe with the quadratus lumbarum block. Interestingly though, when we look at breast surgery, the literature suggests the PEX-2 block remains slightly superior to the ESP block. This makes physiological sense, as the PEX-2 provides more direct, targeted coverage of the anterior chest wall nerves, whereas the ESP relies on that variable anterior diffusion we discussed earlier.
Tracking the ESP block along the perioperative ERAS pathway truly highlights its value. Preoperatively, placing a single shot or an indwelling catheter sets the stage. Intraoperatively, this translates to a sharply decreased systemic opioid demand, which means less remifentanil or fentanyl, resulting in remarkably smoother, more predictable emergences and faster extubation times. Postoperatively is where it really shines. A bilateral ESP block essentially mimics the analgesic profile of an epidural, but completely lacks the frustrating autonomic instability. No profound hypotension from sympathectomy, no urinary retention. While a high-volume single shot often impressively outlasts a standard paravertebral block due to the avascular nature of the fascial plane slowing absorption, the true analgesic runway can be vastly extended via a continuous catheter. Running an infusion of dilute local anesthetic at about 0.1 milliliters per kilogram per hour can provide days of seamless, opioid-sparing comfort, drastically accelerating the patient's physical therapy and recovery.
Section 5. Safety and Complication Profile. Evaluating the risks.
One of the primary reasons we've embraced this technique is its reputation for safety. Because our needle target is external to the neuraxis and relatively superficial, it remains highly safe to perform even in fully anticoagulated patients. That is a massive clinical advantage when navigating modern surgical populations on dual antiplatelet therapy or therapeutic heparin. However, as experienced physicians, we know that safe does not mean risk-free. Isolated case reports in the literature must serve to keep us vigilant. There has been a documented case of a pneumothorax in an adult, a stark reminder that if you lose sight of your needle tip and plunge past the transverse process, the pleura is right there waiting. Furthermore, unexpected lower extremity motor weakness can occur. If you are doing a high-volume lumbar ESP, that anesthetic can track deeply into the lumbar plexus or even via the intervertebral foramina into the epidural space. We've also seen rare reports of Harlequin syndrome, unilateral facial flushing and sweating, which happens when the block tracks high up the sympathetic chain in the upper thoracic region. And most importantly, local anesthetic systemic toxicity, or LAST, has been documented in 2 adults and 1 neonate. Remember, you are injecting a massive volume of drug into a highly vascularized muscle plane. Always calculate and respect your toxic dose limits and aspirate frequently.
Section 6. Pediatric Focus and Future. Anatomical Variations in Neonates and Infants.
Finally, we must adapt our understanding for our most delicate population, pediatrics. You cannot treat a neonate or an infant simply as a scaled-down adult. Their anatomical differences completely alter the dynamics of local anesthetic spread. Sonographically, as you can see in these brilliant images, the pediatric landmarks are highly distinct and much more superficial. In young infants, the bone is less calcified, so the acoustic shadowing isn't quite as dark. The erector spinae muscle appears as very clear, distinct hypoechoic bands sitting in intimate, tight contact with the underlying bony structures. You can clearly differentiate the spinalis, the longissimus thoracics, and the superficial fascial layers. Because clinical assessment of a sensory block in a crying, nonverbal infant is notoriously difficult, if not impossible, our reliance on precise ultrasound-guided fascial plane deposition is absolutely paramount for procedural success. You have to trust your visual spread.
And the way that spread behaves is fundamentally different. Young infants possess relatively shorter transverse processes compared to an adult's skeletal structure. This subtle geometry means that an injection placed precisely at the tip of the transverse process inherently sits much closer to the midline, closer to the neuraxis. Consequently, the local anesthetic spreads far more medially, easily slipping past the costotransverse ligaments and penetrating into the paravertebral space to block both the dorsal and ventral roots, as well as the sympathetic trunk. On top of that, their fascial planes are significantly thinner and highly porous compared to dense adult fascia. Therefore, when utilizing a standard pediatric dose of 0.5 milliliters per kilogram, you yield an immense volume of spread. It effortlessly covers at least 5 dermatomes, and often more, providing exceptional, profound, and highly opioid-sparing analgesia for major pediatric thoracic and abdominal surgeries.
As we conclude, we must look to the horizon. As we continually push the boundaries of regional anesthesia and refine the SP block, we are left with some profound questions to ponder. Moving forward, how will large-scale, multi-center randomized controlled trials successfully isolate the true mechanical nerve blockade effect from the purely systemic absorption of these large doses of local anesthetics, especially when we are talking about anterior chest wall surgeries where the spread is highly variable? And ultimately, with the varying degrees of fascial porosity and vascularity, what will be defined as the absolute, definitive, optimal dosing and concentration for our youngest, most vulnerable pediatric patients to maximize efficacy while guaranteeing safety? These are the fascinating questions that will drive the next decade of research in our specialty. Thank you so much for joining me for this deep dive explainer. It's been an absolute pleasure, and I look forward to exploring the quadratus lumborum block with you in part 2.